Announce session number 6. Professor Rafat Rashwan, Professor Amr El-Ligi, Dr. Ayman El-Mulufi, Professor Hani Hamad, Professor Mazen Ataya, Professor Megahid Abu El-Magdi, Professor Rasha Azmi.
About the concept of early treatment and intensification by Professor Mohamed Hassanien.
Bismillahirrahmanirrahim. Thank you, Professor Rashwan, the chair. Hopefully you will not get bored with me again, but I hope it will only be a short presentation. So we're now discussing the points of treatment of type 2 diabetes and the importance of early management and the best strategy for treatment. I think you have seen this slide partially presented by Professor Dario, where it is unfortunate factor that we all have to remember. A male or a female with diabetes loses life because of the fact that they have diabetes. So here, you see here, the loss of life because of vascular death in men and in women, and obviously non-vascular death as well. So on average, a person who's 50 years of life with diabetes and no previous history of vascular disease will probably die 6 years younger than another person who does not have diabetes and no vascular disease as well. You have seen this and you have practiced it several times in your life, the data that says to us the importance of glycemic control. And should we have a target and a figure? We do not treat the person for one organ. We treat a human being. I treat the human being to protect his heart, to protect his brain, to protect his peripheral arteries, to protect his kidneys, his eyes, his nerves. Every part of the individual that is related to hyperglycemia need to be treated. And if you look here to the data, for example, for retinopathy, who would like not to see well? Nobody. Who would like to have distorted image because of diabetes or because of any other illness? The data for microvascular complications, relationship with glycemic control, has no doubt whatsoever. And it is not related to a type of drug. It's related to glycemic control. And this is the data from the UK PDS and from other studies saying to us that tight glycemic control or better glycemic control has much lower rate of retinopathy. And for the sake of the time, I've only shown one of them because vision is really quite important, and it's a good example. Of course, we have targets. We have an overall target, but I'm not going to dissect the target based on the organ. I'm going to dissect the target based on the risk of the individual. So if my overwhelming problem is microvascular, then I need to get the target as low as possible. If I have no microvascular problems and my health is frail, then the target for microvascular disease, for heart condition, is not so tight. But we need to have targets. When we have targets, we are happy. I'm a Liverpool fan for over 20 years. I was happy to be in Madrid myself, carrying the Egyptian flag, and was delighted to see Mohamed Salah lifting the Champions League Cup final. That makes my life very happy, and so is so many other people. But targets in normal life in diabetes are difficult to achieve. As you can see from this slide, here is data from different years. On an annual basis, in this particular cohort, they looked into 1.66 million person with diabetes data analyzed. And as you can see, those who achieve good control of HbA1c up to 7 is no higher than 60%, even in Western societies. 31% are not achieving target in another study of the code 2. Here, the target was less than 6.5. So overall, we have lots of people, lots of centers, lots of doctors, lots of patients, all being frustrated, not clear or not able to get the control. There are barriers that we think the problem is the patient, and equally the patient can sometimes blame the system, the doctor, the medicine, and so forth. Two big factors of whether it's coming from the patient or coming from us as doctors is the impact of treatment on weight and the risk of hypoglycemia. It is really quite philosophical that we are treating a condition characterized by hyperglycemia. But the major problem when we come to treatment is the opposite, hypoglycemia. Hypoglycemia is not a feature of diabetes. Hypoglycemia is a feature of the treatment of diabetes because of the lack of purity of the treatment that we use. If the treatment that we use was equivalent to the pancreas given to us by Allah subhanahu wa ta'ala, we would have no hypoglycemia. But we have to balance things based on what we have. It's like this very high artistic balance of these stones, one stone on top of the other, and you can see they do not fall. So in life, when we come to the treatment of diabetes, we equally have to think of timely, effective, stable glycemic control that would reduce the risks of complications, whether this is microvascular complication, macrovascular complication, infection, so many other aspects. But also the impact of the treatment on the weight, on the hypoglycemia, and of course on how can I make the treatment easy for the person? How can the person adhere to the treatment with ease? One of the important factors is physicians' inertia. And this is something that we really need to all to fight and to try to get better. I don't know whether you have seen this slide before or not, but the reality is a person on monotherapy will stay for 2.9 years, not perfectly controlled, before they go to dual therapy. If they are already on dual therapy, it will take them 7 years to go on a third line. If they're already on 3 different drugs, tablets, to go on insulin, it will take them another 7 years. So clearly there is inertia that we all need to try to overcome. Now, some of the barriers we say is the complexity of the treatment, the impact of the weight, the impact of the hypos, the lack of funding, and so forth. But I think this is really quite important for all of us to remember, because if we look into type 2 diabetes who remain with poor control for over 7 years before we intensify to the second line of oral therapy or insulin, that should not be the case. It should not be at all that we wait for such a long time. If you aim even for a higher HbA1c, if you say 7% is too low, let's raise the target to 7.5%. And still the target will be not achieved for a very sizable proportion of our patients. Now the question was raised earlier, and people started to wonder, does it matter if my patient is perfectly controlled or averagely controlled or not? Does it matter if I start the treatment today or in a year or two? And the answer is yes, it does matter. When you look into this slide here, when you look into this area with this gap, the difference of a person who was timely treated in comparison to a person who is delayed in treatment when it comes to myocardial infarction, stroke, heart failure, and the composite endpoints of cardiovascular events, all of these were statistically significant for those who who were well controlled, timely controlled in comparison with the others. We know that the disease is progressive. We know that monotherapy, went a bit too far. We know that one drug is probably not enough. Usually you get good control, and then after some time the control escapes. And unless you add another drug in a timely fashion, then you have a problem. Here is the AASD guidelines, not the latest one, the previous one. It doesn't matter which one you use. What matters is we have an algorithm and we have a scheme, and we should try as much as possible to apply that scheme. Unfortunately, we end up with some of the points that we forget. We completely forget lifestyle. All our concern is the prescription that we will give to our patient. What does it include? Drug A or drug B or drug C, and so on. And the lifestyle, we spend very little time explaining to the patient, cut this, or walk a bit more, without a comprehensive program. And the most important aspect in the management of diabetes is patient education. The question that was raised earlier is change in behavior. Does it happen or does not happen? Well, how much of our program of the conference is related to patient education? We focused far too much on the therapy, and we forget that this is really quite an important aspect. But even with the therapy, there is another important factor, is selecting when do we go for monotherapy or for dual therapy. This is the Canadian guidelines. And what does the Canadian guidelines says? That when you choose based on patient characteristics and age of characteristics. But also it says, as you can see here in the middle, if the HbA1c is above 8.5, then consider initial combination with another anti-hyperglycemic agent on top of metformin. So we don't have to wait if the person, at the time of the therapy initiation, if their average is well above what is recommended, you can consider, as the Canadian recommendation have said. And it's not just the Canadian, it's the ADA and the AASD has also said this. They moved it slightly higher to 9. So whether it's 8.5 or whether it's 9, the established guidelines for many years are saying to us is, your patient is not well controlled, go to combination therapy. What would be the components of the combination therapy? That is a matter of discussion between you and your patient, and a matter of consideration of the drug characteristics and the patient characteristics. But what is important is that we really read the fine print. And one important point of the fine print, it says, when should we adjust the treatment? It's not after 6 years or 1 year, it's after 3 months. So I have today started my patient on drug A, and I have reached the maximum dose of drug A. The patient is still not well controlled. 3 months later, I need to think of drug B. And that is really quite explicitly written in all of the recommendations. The choice of the drug B is based on all of these important factors. The efficacy of the drug, the safety of the drug, the impact of the drug on weight, the impact of the drug on hypos, and of course, the cost of the drug. So all of these factors will make me choose for patient 1, this the drug, for patient B, another one for patient C, possibly a third one. If we apply this yo-yo process of one drug and we wait for a long time and we get out of control, it could be a long process. Ideally, you want to cascade your treatment a bit in a more aggressive fashion so that your patient remains in good control rather than escapes control and keeps going higher and higher gradually. I would like now to focus for the last few slides on patient adherence. Patients and adherence to treatment is different or slightly different than compliance. Adherence is taking the medication and also taking it in the right process and the right timing. And we all know that adherence is directly related in diabetes to HbA1c. It's common sense. I take the drug, the effect will be there. I take the glycemic drug, then the effect will be there. I take the blood pressure treatment, the effect will be there. I stop the blood pressure and the glycemic control will bounce back. This is data from America looking into people with diabetes who were admitted previously to hospital and then they were prescribed a treatment. And they looked into the new prescriptions. This is data from a very comprehensive insurance scheme and it's been published a long time ago. And they looked into important factors. Admission to hospital and mortality. Non-adherence, even in the States, was 21%. And interestingly, the non-adherence was worse in the younger group compared to the older group. You expect the older person to be on multiple therapy and they might be resistant. But maybe the wisdom of age makes them adhere to treatment in comparison to the younger. Did it matter when it comes to admissions or mortality? And as you can see from the figure here, from the table here, there's a clear difference between the group that were adherent and the group that were not adherent. So if I were to go again to the feedback of patients on what are their barriers, the regimen complexity and adherence to treatment are one of the important factors. If the drug has a low side effect profile, if the drug is easy to take, then the likelihood of the person taking that drug is a much more than a drug without these characteristics. And combination therapy, when you combine two different antihypertensive, two different glycemic control drugs, or even the polypill they were talking about in the past, that might help. This was studied in tuberculosis treatment, in HIV treatment, in hypertension treatment, and in diabetes treatment. This combination of the more than one drug in one single pill. I remember my mother, rahmatullah alayha, she had diabetes. And she used to put all her tablets in her palm and tell me, look how many tablets I take. So patients count the number of tablets. So when you move from drug A to drug A plus B, and they're both in the same tablet, the patient does not feel that they are getting worse and they need two different agents rather than one agent only. And here is very clear data on the relationship of number of pills in regard to compliance. If you give your patient one tablet, they're much more likely to take it in comparison to giving them 4 or 5 different tablets. So my take-home messages are simple. When we think of a holistic approach, that is far much better than thinking of simple solutions one after the other. A collective holistic approach is important. Multiple drugs in combination that act in a synergistic way that addresses different pathophysiological problems. This one is insulin sensitivity, this one is another aspect of the pathophysiology of diabetes is better. When we think of the pathogenic problems of people with diabetes and try to address them, and when we think of the early intensification of treatment without unnecessary delays, then we can save many of our patients. Now, we have a new concept, and it's a question mark that we will hear from our colleagues is, should we do this regardless of the level of glycemic control? Should we think of early combination therapy regardless? I think the one thing that we all agree about, that our ideal drug need to be high efficacy, weight neutral or make the person lose weight with a very low risk or no risk of hypoglycemia, that will address both the fasting and the postprandial, that will be simple to administer, not too complex and not too painful, with a low profile side effects, with evidence, and is cost effective. The name of this drug is, I don't know. It's not existent yet. So I leave you with, again, with information about the Diabetes and Ramadan Conference. and my beloved home city, Alexandria. Thank you.
لو في حد عنده سؤال يحب يوجهه للاستاذ الدكتور محمد حسنين، اتفضل.
I was hoping to escape questions.
Yeah. What?
I was hoping to escape questions.
Do you think that the next year the guideline will be changing after the beneficial effect and the benefit of the combined therapy in the beginning of treatment of type 2 diabetes, especially that these patients use this combined therapy, reduces the initial failure by more than 50% and second failure by about 26%. Do you think that the guideline will be changed even in patients with A1C about not more than 7.5%?
I think it's a pretty early stages yet to lead to changes in guidelines. I think people are very much focused on the data and the evidence from multiple cardiovascular outcome trials and kidney and CKD trials that influence the guidelines. Whether the point of should we initiate with dual therapy or with monotherapy, I think, to be honest with you, how many of your patients, when you initiate therapy on a newly diagnosed HbA1c, is below less than 8.5? 8.5. How many of your patients that are newly diagnosed? But the vast majority of patients, when they come to the doctor and they are to initiation of treatment, their HbA1c is usually high. And with this group, in the Canadian guidelines, in the AASD guidelines, in all of the guidelines, it says use combination therapy. So the fight is on those that you pick up early and they are not at such a high HbA1c. Maybe you can ask the question again at the end of the session after reviewing the data and giving everyone the benefit. I don't want to give my personal opinion before the session proper of the study starts.
Well, I have two questions. One of them is the delay in intensification therapy. There is progression of diabetes. And if diabetes is responding now with one drug, why do I give it 3 or 2? So most doctors find results initially. So, and if it's after 7 years, he needs 3 medications, partly that is because the disease has progressed. And the question is, at what level can you define that all what you have done was successful to justify a second medication? Is it a level that you look at? And is that level A1C? And if that's a number, it's easy to define. And if it's easy, we shouldn't be running into that dilemma. Do you think so?
Yes, I think the answer is simple and easy. We have guidelines, we have algorithms. It specifies to us the initiation line is what? What is the first line therapy? We have criteria for the choice of the second and third and fourth line therapy. And we have criteria for how soon should we wait. It's usually 3 months. If you want to exceed it a bit, 3 to 6 months. But to wait for years is unacceptable. So is it a target figure? Yes. And you can adjust the figure, of course, based on the individual in front of you. Someone quite young and healthy, I would aim for less than 7, 6.5. Someone a bit older or with lots of comorbidities, my target will change. So once we agree together as doctor-patient a target, if we are out of target for 3 to 6 months, we should move to the next step.
Another thing on the slide you presented, the third objective was to preserve or reverse the beta cell function. Which drug does that?
Well, don't forget that at the time of diagnosis, there is glucose toxicity and lots of damage because of glucose toxicity. We have learned from Diabetes UK, from UKPDS, sorry, that at the time of diagnosis, 50% of the beta cell function is damaged. But I'm not sure that this is the reality, because we see lots of patients initiated on an incretin, a GLP-1 or DP4, in studies 8 years after diagnosis. So if at the time of diagnosis I already lost 50%, then after 8 years, how much is preserved? And how come these drugs will still function or even self-annihilate? So I think, without going into too much of academic philosophical points, is let's all be proactive, let's treat our patients according to the recommendation in a timely and appropriate fashion. We are lucky, we have plenty of options nowadays. It's like an open buffet. You have loads of options. When I was young, in treatment of diabetes, the options were very limited. So I think we should not have excuses of with sophistication of, is the target 7.5 or 7 or 6.5? Let's agree a target and get to it, and then we can further lower it down. Thank you.
Thank you, Professor Mohamed, for your excellent talk. I only have a comment. For the last slide, please. For choosing the treatment for treating diabetes, you think put the benefit of the drug. You know, now we have benefits of many drugs give us benefit, as in heart failure or renal diseases. We should put in consider these three drugs, even they are expensive, but in the future they will be more cheaper.
Well, I agree with you, of course. The protection, the added benefit of the drug, that is important. One drug might lower the blood pressure, one drug might lower the weight, one drug might protect my kidneys or my heart. But let's not forget, glycemic control has a marvelous effect on microvascular complications in general. And we should not forget that this is one important aspect, because it does look to me like the diabetes academic field has all stopped on the discussion of two classes only and forget about everything else. My patients have severe neuropathy, have retinopathy, have erectile dysfunction, have infections, foot ulcers. All of these are really serious conditions that also need to be addressed, as well as the heart failure and the cardiac disease and the CKD.
شكرا دكتور.
Thank you.